Assalamu alaikum. I am Feroze, Professor of Surgery working in Popular Medical College and Hospital. This is indeed a proud privilege for me to be on this virtual platform of BIMSSCON 2020, which is organized by IFMSA Bangladesh. This is the, if I'm not wrong, the 4th edition of this program. I really appreciate International Federation of Medical Students Association that they take up this type of program quite often on. These will obviously develop an enthusiasm among the medical students and the young medical professionals in their different developments of their career. Today, in this pandemic situation, since having a conference or a workshop which is in person, since it is not possible, this is a virtual platform on which IFMSA has organized this type of program. I'll be talking on surgical site infection. We are going through a pandemic of COVID-19, which is a coronavirus infection. Apart from that, the title of my book is Surgical Site Infection Control Strategies. I take interest in medical education, in teaching, in development of medical skill, and also taking part in a team of embarking on good quality surgery to reduce the morbidity and the mortality of surgical patients, of which surgical site infection control, prevention, and treatment is a component. So with these few words, I'll start making my presentation. So talking about surgical site infection, as you all know, what is an infection? And if this infection occurs in and around the site of surgery, this is in a nutshell, is a surgical site infection. So, adult human body is composed of 10 to the power 13 number of cells. This is a huge number. And if you look at it, but we are harboring around 10 to the power 14 number of bacteria within our body. So you can well understand the tremendous bioburden of bacteria that we carry in a normal situation. As such, this is a great important issue to take care of these bacteria so that these do not cause any infection at the surgical site, leading to increased morbidity and mortality of surgical patients. Now let's talk about what is surgical site infection. Well, surgical site infections are associated with surgical procedures and a major source of postoperative illness. These infections are responsible for approximately 1/4 of all nosocomial infections in the whole world at a particular point of time. So what goes wrong if surgical site infection occurs? It will increase the hospital stay, increase the post-operative morbidity and mortality, and will have higher cost for healthcare providers and the payers who receive these medical treatment. So this is a difficult situation. There was a study which is said to be a scenic study as regards to nosocomial infection control. What they have seen in this study is that around 6% of the infections can be prevented by minimal infection control efforts, and 32% can be prevented by organized, highly sophisticated, effective control of infection strategies. So we have got to take care of the 6% and 32% of the patients so that we can prevent a great load of surgical site infection and its possibility in a surgical patient. Let's see what we really mean by surgical site infection and what are its different types. Well, surgical site infection occurs within 30 days of operation, and it involves the skin or the subcutaneous tissue in and around the line of incision. This is said to be superficial incisional surgical site infection. This is one type. Here again, I say that this infection occurs within 30 days after operation, involves only the skin and the subcutaneous tissue along the line of incision. And the characteristics which the superficial incisional surgical site infection has is that the wound site will have a purulent discharge with or without laboratory confirmation from the superficial incision. And a diagnosis has to be made by a qualified surgeon or an attending physician. This is the first type. The second type, it also occurs within the first 30 days of the surgical operation. If there is no implant given, and if there is an implant or prosthesis is given in the surgical field in the form of, say, rush nail or screw, in that case, the duration from 30 days goes to 1 year. So if there is no implant, the surgical site infection occurs within 30 days. And if there's an implant in the surgical field, then it is within 1 year of period. If there is an implant in the surgical field and the surgical site infection is said to occur within 1 year of that particular time. And it involves the deep soft tissues like fascia and the muscle layer along the line of incision. So there also, there will be involvement of deep incision spontaneously. Wound dehiscence may occur and abscess may be found from the deep incision. And diagnosis has to be made by a surgeon or an attending physician. Third and the last type is the organ space surgical site infection. Here also it occurs within 30 days if there is no implant, and within 1 year if there is an implant in place and the infection is related to the operation, and infection involves any part of the anatomy which is opened or manipulated during operation. So within the organ space, it is deeper to the abdominal wall if it is an abdominal surgery. So it occurs within the peritoneal cavity, within the any retroperitoneal space. So these are organ spaces where this infection takes place. So to recapitulate again, the surgical site infections can be superficial, can be deep, and organ space surgical site infections. Now, what are the pathogenesis associated with surgical site infection? What are the organisms involved? Well, as regards to the involvement of the organisms involved in the development of surgical site infection, we have both gram-positive and gram-negative organisms. Gram-positive bacteria include the Staphylococcus aureus, Staphylococcus epidermidis, methicillin-resistant Staphylococcus, methicillin-resistant Staphylococcus epidermidis, and gram-negative bacteria include Escherichia coli and Klebsiella pneumoniae. So these are the common pathogens responsible for surgical site infection. Center for Disease Control has classified wound into different categories. These categories are either class 1, class 2, class 3, or class 4. Class 3 is synonymous with clean wound, class 2 clean contaminated wound, class 3 contaminated wound, and class 4 dirty infected wound. I'm not going to the details of all these classifications, just so we know the less infection is class 1, the most severe form of infection is class 4 infection. And the synonym for all these are already stated within the slide that is being presented right now. We can again classify the wounds in a general way according to the skin layer involvement. It can be superficial, it can be partial thickness, it can be full thickness. Superficial wounds are the wounds which involve only the epidermis, and partial thickness wound involves the epidermis as well as the dermis, and full thickness wound involves epidermis, dermis, fat, fascia, and it can even expose the underlying bone. Then again, if we go back to CDC classification, we have said wound can be clean, contaminated, and dirty. The clean wound has already been again said as a well, from the time you have an wound, the phase of inflammation begins. The extent of inflammation increases gradually, reaches a peak, goes down gradually in 7 to 10 days time. Before the end of the phase of inflammation, the phase of proliferation begins, and it again reaches gradually to a peak, again comes down to the base. The third one is the maturation phase, which begins at the same time, that is towards the end of the inflammation phase, goes along with the proliferation phase, and continues even after the end of proliferation phase. And that is the last phase. So these three phases of wound filling that takes place in a human body if you want to have a healing of a wound. Healing process begins from the moment you have the trauma, from the moment you have the injury. So from day 0 to day 5, what happens? This healing process begins from the moment of injury. Firstly, clotting mechanism comes into action. Then inflammatory phase is characterized by increased temperature, swelling, redness, pain, loss of function at the wound site. Then in the early part, you have hemostasis. Late stage, you have phagocytosis by the neutrophils and macrophages. This phase is short-lived and in absence of infection or contamination. If you have any contamination or infection, this early phase, that is 0 to 5 day phase, will be hampered, will be jeopardized, and as such, wound healing will not take place properly. Next develops granulation tissue. There is formation of granulation tissues. There is multiplication of cells of fibroblasts, inflammatory cells. There are new capillary buds embedded in a loose extracellular collagen matrix, fibronectin, and hyaluronic acid. So these are added together at the site of wound. during a phase of granulation tissue, and it takes place from 3 to 14 days. In this particular period, there is angiogenesis. Angiogenesis means that is proliferation of the blood vessels. Within the collagen tissue, you have fibroblasts, and there is endothelial cell proliferation. And as a result, there is granulation tissue which becomes red and healthy, and it bleeds on touch. Now, if you have a wound, a developed wound, then how do you assess? You'll have to assess by having a look at it, take a good history, and you have to have some laboratory investigations. So when you find a wound, you just expose it, have a good light, good illumination, look at it properly, you'll find the signs of infection. So what are the signs of infection or inflammation? You'll have redness, increased temperature, swelling, and loss of function of that particular area. If you smell, there will be foul smelling odor. You'll have to look at the wound age. That will determine the type of wound. You'll have to look at the surrounding skin color and the presence of moisture surrounding the area of the wound itself. You'll have to measure the size, that is length, breadth, and the depth of the wound. You'll have to look at the wound and feel the wound bed, which is said to be the base of the wound. If there is any debris present on the wound bed, is there any granulation tissue, that you have got to look properly and then take necessary steps for taking care of the wound or management of the wound. Infected wounds can be graded as grade 1, grade 2, grade 3, and grade 4. Grade 1 is a minor wound. It doesn't blanch when there is erythema. Discoloration of the skin, warmth, edema, induration, hardness may be seen in dark-skinned people. Grade 2 is a partial thickness skin loss involving epidermis and dermis. This is what is grade 2 wound infection. Grade 3 is full thickness skin loss, and grade 4 is the extensive destruction with tissue necrosis and bone may be exposed. So grade 1, grade 2, grade 3, grade 4. This is the classification of infected wound. Now, having said a little bit about wound infection, surgical site infection, its definition, classification, and all these. Now let us look at the factors that interferes with the colonization of the organism. As we all know, for infection, there has to be presence of microorganisms present, and they have to colonize in that particular area. They'll multiply, will liberate toxic materials with the production of signs, symptoms of infection. So what are the factors responsible for colonization of the organisms leading to surgical site infection? You know, these factors can be classified as certain factors related to the patient, factors related to the operative procedure of the technique. There are certain situations of the post-operative period, which is a factor, and presence and absence of implants. And if there are presence of implants, the different types of implants will interfere with the susceptibility of development of surgical site infection. So the factors involved are patient-related, procedure or technique-related, post-operative factors, and absence or presence of the types of implants present in the operative field. Let's come one after another. The patient-related factors include age of the patient. Advanced age, elderly people, they have more susceptibility to develop infection, and as such, surgical site infection is no exception to it. The nutritional status of the patient. The malnutrition interferes with wound healing. As such, surgical site infection is also more common in presence of a poorly nourished status of a patient. Well, if a patient is obese, obesity interferes with wound healing, and as such, surgical site infection is more common in obese patients than in thin people. Diabetes mellitus is a factor which interferes with wound healing, which enhances infection, and as such, the surgical site infection as well. As you all know, why diabetes mellitus is a factor for development of infection. There are certain factors. One factor is increased concentration of the glucose in the area where the wound is present along the line of incision. So these increased glucose is a food for the multiplication and development of the organisms. As such, the organisms multiply and give rise to infection. The diabetes produces microangiopathy. There's decreased vascularity, and decreased vascularity jeopardizes the wound healing. Thirdly, diabetes mellitus reduces the immune status of a patient. So as the immunity goes down, the external bacteria gets upper hand to fight with the patient, and they take the lead and produce surgical site infection. If you have a history of smoking, that also enhances surgical site infection. If you have a focus of infection away from your surgical site in your body, say you're making an incision in the anterior abdominal wall, you have an abscess in the left toe, left great toe. Well, that infection from that left great toe may go into the surgical site of the anterior abdominal wall and can lead to surgical site infection. As you all know, some patients who are subjected to surgery are on chronic steroid therapy. So steroid, as you know, is an anti-inflammatory drug. So if you do not have inflammation, there is patient-related factors. If you want to add more, if the patient has chronic inflammation anywhere in the wound, if the patient has an open wound in the body, if the patient is receiving radiotherapy for any reason or the other, if the patient is immunosuppressed, these are all liable to develop surgical site infection. So these factors must be taken into account when you embark on doing surgery, and we should take necessary steps, these patient-related steps, to prevent surgical site infection. The another important factor is the length of preoperative stay in the hospital. If a patient stays in the hospital for longer period of time, they are more susceptible to develop surgical site infection. So it is customary that you should try to admit the patient as late as possible, and the gap between the admission and the time of surgery should be as minimum as possible to prevent surgical site infection. Now, having said all the patient-related factors, the next factor, which we said is a procedure-related or technique-related factors, which include the duration of operation. If it is a surgery which involves a long period of time, long duration, that has a more susceptibility to develop surgical site infection. If the duration is short, you have less susceptibility, less possibility. Duration of surgical scrub. If you scrub, if you take a good scrub, both the surgeon and the operative field for a pretty long time, abiding by the healthcare regulations, then there will be less incidence of surgical site infection. So a point of importance is preoperative shaving, skin preparation. Well, talking about preoperative shaving, the recent protocol is we should not shave the area of the operative field until and unless it really creates a problem making incisions and doing the surgical procedure. Although previously it was said, and it is also in practice in certain situations, that the preoperative order which you give the day before the surgery is clean and shave from mid-chest to mid-thigh. This concept is no more valid. If a patient is not very hairy, does not interfere much with making a good incision, don't go for doing any surgery. Don't go for doing any sort of shaving. The reason being, if you shave, that shaving area will have some sort of injury where the organisms will settle down and will develop infection. So if possible, don't shave at all. And if you at all have to shave, do not use blade. Do not use razor. Use clippers. Clippers are much better. Clippers are what? Clippers are nothing but the trimmers that you often use who keep small beards. They just trim their beards, somewhat like me. They use trimmers. So use trimmers for shaving if shaving is at all required. And when should you shave it is required at all? The shaving should be done preferably in and around the operation theater with a minimum time duration between the time of shaving and making an incision, so that if there is little amount of trauma to the skin and the subcutaneous tissue during shaving, there is very minimum time for the organisms to settle down there and multiply, causing infection, and there is entry of organisms into the incision. So minimum time period given for the organisms to settle down and multiply. So shaving, if at all required, the time duration between the shaving and the making an incision should be as minimum as possible. Regarding skin preparation, proper skin preparation of the patient is a must. We must properly paint the surgical field. The method should be from center to periphery with either chlorhexidine or povidone iodine solution. Inadequate operation theater ventilation will interfere with surgical site infection. Inadequate sterilization of the instruments are very important issues. So there must be proper sterilization of the instruments, and facilities must be adequate and must be checked regularly for having a good surgical outcome, having less or no surgical site infection. Well, surgical technique itself is an important issue or factor for the development of surgical site infection. If you are very crude, rough in handling tissue, leave behind blood, leave behind dead tissues, do too much of electrocautery, these will lead to preponderance of development of surgical site infection. So you must be meticulous, doing adequate hemostasis. Do not use too much of surgical diathermy, and then do not leave behind the dead space. So these will facilitate not to develop surgical site infection. I said poor hemostasis, so do hemostasis properly. Failure of obliteration of the dead space. Do minimum tissue trauma. Use of skin preparation, that is, I said, the painting of the operative field. And another important issue is antimicrobial prophylaxis. So the antibiotics must be judicious, must not be injudicious, must be empirical, must be given in proper places, in proper situations, in proper dose and proper time. Use of surgical drains. We must be meticulous about putting in surgical drains to prevent surgical site infection. You know, if we keep on giving drains, bundles of drains, that is also not good. But where necessary, you must put drain. It is a saying that nobody has said that he has done wrong putting a drain. There are surgeons who says that probably if I would have kept a drain, then I could have done better. That is a saying, but nobody has said that putting a drain is a disaster. But drains must be put in proper situation, proper places, and when having proper indication. So length of preoperative hospital stay, I have said, is insufficient preoperative preparation, personal hygiene, hair removal, skin disinfection of the patient that has already been said, insufficient antibiotic therapy, intraoperative hypothermia. When patient is under general anesthesia, patient being operated in an air cooler, temperature being low down, there is every chance that patient might develop hypothermia. So that must be kept in mind, that patient does not develop hypothermia. Patient does not develop hypoxia. Pulse oximeter and oxygen saturation must be maintained above 95%. Intraoperative hypotension is an important factor. If the patient remains hypotensive for a long period during operative period, these patients are susceptible to develop all sorts of morbidities following surgery. So intraoperative hypotension has to be controlled. So proper blood pressure maintenance is an important issue for having a good outcome of surgery. Regards to incision care, after doing the operation, there must be a sterile draining kept on the incision. Dressing may be changed after 4 or 5 days, and patient may be discharged with the dressing, and patient will take care of the incision at home. If they are being taught properly and their facilities, there is no use keeping the patient in the hospital for a long period of time. Additional factors which affect surgical site infection include gowning problems. When the surgeons walk, they must be properly gowned. There is emergence of resistant organisms that must be taken into consideration. The debilitated patients, the elderly patients, immunocompromised patients having comorbid illnesses, they must be taken care of properly, because these patients are more susceptible to develop surgical site infections. Say a patient with kidney transplant, he had a transplant kidney 5 or 6 years back, and everybody has forgotten about it, and the patient has presented to the surgical OPD with cholelithiasis. Having taken no good history about the kidney transplantation 5 years ago, we go into elective cholecystectomy, taking no care of the immunosuppression that the patient is having due to the kidney transplant, because transplanted patients are always on immunosuppressive drugs. So good and proper past history must be taken. We must do an inquiry about the placement of prosthetic implants present in that particular patient who will undergo surgery. So patients having prosthesis or implants are more susceptible to develop surgical site infection. So they should be given more care to prevent and deal with surgical site infection. Now, for having a surgical site infection, what do you require? You require a number of bacteria which must settle down, multiply. And these microorganisms must have virulence to cause infection. So it is the amount of bacteria or contamination that is present, it is the amount of the virulence of the organism present, and it is the resistance of the host. All these 3 factors with a cumulative effect will determine the risk of surgical site infection. So more the amount of bacterial contamination, more the virulence of the organism, more is the risk of surgical site infection. More the resistance of the patient against these organisms, against the virulence of the organisms, less is the risk of surgical site infection. That is why it is said that dose of the bacterial contamination into virulence of the organism divided by resistance of the host determines the risk of surgical site infection. That is, the dose of bacterial contamination is directly proportional to the risk. Virulence of the organism is directly proportional to the risk of surgical site infection, and resistance of the host is inversely proportional to the development of surgical site infection. There is a concept of biofilm that is produced in around the microorganisms which multiply, which is a sticky material which further enhances the organisms to settle down and multiply. So that is a point. If you can break down this biofilm production during the multiplication of the organisms, we can reduce the infection. Post-operatively, bacteria may contaminate the tissue and the surgical wound as well as the suture material itself. Suture material itself may be engulfed by the organisms. Furthermore, the bacteria develop extracellular polymorph that promote greater adhesion and resistance to antimicrobial treatment. So this looks a bit difficult. It's not much importance for people of your stage. So if we consider that we need fewer bacteria for development of infection, implants provide needles for attachment of the organisms. Infection is more difficult to treat because of the biofilm formation. So if there are any mechanism that we can develop to dislodge this biofilm, we'll be able to get away with the surgical site infection. You just remember this much. So nothing much to know about biofilm at this stage of your career. So what are the additional factors? That is the indirect cost involvement of the patient if a patient develops surgical site infection. The long productivity is lost, temporary or permanent impairment of physical function, decreased patient satisfaction, increased referral, because patient is referred from one doctor to another, from one hospital to another hospital, and patients may have a tendency to cause medical litigation. They'll sue case in the court that I went for a small purpose for doing a surgery. It was not supposed to have an infection at the operative field. So there has been an infection. I'm staying in the hospital for a long period. I'm jobless. I have spent a lot of money. So goes to the law enforcing agent to deal with the matter. And the doctors, the hospital, and the patients all are put into trouble, which indirectly involves the financial status. Direct cost involvement, as the patient will have a long hospital stay, so he'll be away from his job. Patient might have readmission after being discharged. Outpatient and emergency care visit may be required. Additional surgical procedures in the form of incision and drainage or stage reimplantation may be required. Prolonged antibiotic therapy, increased use of ancillary service like hospital revisits, subjected to radiology, laboratory investigations, increased requirement of drugs and medicine, which takes a lot of cost for that particular patient, which becomes a big burden and is a direct cost involvement for surgical site infection occurring in an operating patient. Now, if we keep the surgical site or the operative field at the center, what are the factors of the microorganisms that should be taken into account to reduce the surgical site infection? We have said one is a patient factor, operating room, the instruments and the tools, and the medical facilities, that is surgeons, doctors, nurses, paramedics, technicians, their precautions and different steps all move around the center of the surgical site. And if we take necessary steps as regards to patients, as regards to operating field, as regards to surgical team, and as regards to the instruments, then we'll be able to prevent surgical site infection. Well, infection control protocol includes, you have to regularly do a good disinfection of the operation theater. Operation theater has got to be disinfected And once you disinfect and keep on doing surgery in that particular operation theater 24 hours a day, 7 days a week, 365 days a year, that will not do. So this must be rechecked, and disinfection strategies must be taken every month or every 2 months, every 3 months, depending the load of surgery in that particular operation theater. And as such, there is a scope for infection control team. ICT is a department that must be there and adequately working in each and every hospital. So that is an important issue that must be taken into account. Skin preparation of the patient, I have already said, it's good that patient has a preoperative, thorough soap water bath the night or the evening before the day of surgery. And the operative field must be properly painted with antiseptic solution just prior to making an incision. I've already talked about hair removal. That patient scrubbing means patient taking a bath and operative field painting with antiseptic solution. Next important factor is antibiotic prophylaxis. I'll be talking about it more in details. Use of sterile instruments. Drapes, gowns, and gloves must be properly sterilized. Drapes mean the draping sheet that covers the operative field, leaving behind the point of incision and covering all the areas around. That is said to be drapes. Gowns, gloves, and proper dressing of wounds. These are the different steps that must be taken. This protocol must be used. So, my dear young budding surgeons or physicians or medical professionals, whatever you say, this is not one action that you should take to prevent development of surgical site infection. It is bundle of action targeting various aspects that need to be implemented. So reduction in the surgical site infections must be timely, and appropriate antimicrobial prophylaxis must be given, proper control of diabetes, appropriate hair removal, normothermia in general surgical patients. So patients should not be hypothermic, temperature should not go down. So there will be repetition of certain issues which are more important, which you might say that you have said just 5 minutes back, 5 minutes ago. So important things, there will be repetition. So this is an example of an wound where there has been a drain and the organisms are growing. This is methicillin-resistant Staphylococcus aureus. Talking about skin antisepsis and antimicrobial prophylaxis. So preoperative antiseptic shower, which I have said the day before in the evening, does it make sense? Yes, it does. How? It reduces the skin colonization of the organisms. So antiseptic bath should be taken, which is not much in common use in our hospital setting, because the skin harbors a lot of organisms, a group of organisms which are said to be transient flora, and certain organisms are resident flora. Transient flora includes Staph aureus, Streptococcus, and E. coli. These are all dangerous organisms. And there are some resident flora. They remain within the skin epidermis. They are Staphylococcus epidermidis, Micrococci, and Klebsiella. They do not do any harm, but if there is opportunity, there is less immunity, there is diabetes mellitus present, the wound or the skin preparation is not good, patient is not well prepared, so they get opportunity to cause surgical site infection. So operative field must be properly painted. So possible paints that are on common use are chlorhexidine, which you find in the name of Hexisol, Hexiscrub. Then you find povidone in the form of Povisave, and so on. So these are the different organisms. I'm not going into comparison between which organism does what, how long does it stay, is not required at this stage. So these are common organisms, common antimicrobials solutions, chemical solutions that are used for skin preparation of the patient. One can be a chemical preparation, chemical can be used, soap and water scrub, and alcohol preparation. So these are certain possibilities. What do? They reduce the rate of bacterial multiplication, colonization, and infection. So these are much less in occurrence if you have a good antiseptic preparation of the skin preparation. Talking about mask, taking a good preoperative preparation by the surgical team, having a properly owned mask is important. We are not talking about N95 or KN95 mask. Surgical mask, which must be 3-layered mask. So any type of mask will not do. It has to be a surgical mask and 3-ply mask. 3-layered or 3-ply mask must be used, and which must cover the nose and the mouth. So keeping the nose open, or keeping the mouth open, and the mask is hanging from the chin down will not do any good work. So it must be properly owned. Now talking about surgical antibiotic prophylaxis, what is an error in doing that? So certain issues must be taken into consideration. When was the first dose administered? This prophylaxis antibiotic, when was it given first? Was it sufficient to cover the total duration of operation? Did the patient correct dose per weight? So these issues must be answered properly, and then we should use the prophylactic antibiotic. Does the antibiotic have a low minimal inhibitory concentration for that organism? Is there sufficient tissue concentration? Is the antibiotic safe to the patient? So these factors must be taken into consideration when you apply a prophylactic antibiotic to the operating patient. When do you need a prophylactic antibiotic? If the patient who is operated develops a clean wound, in that case we give a prophylactic antibiotic. If it produces a clean wound with an implant, we again give prophylactic antibiotic. Clean contaminated wound, we provide an antibiotic. Contaminated wound, yes, we provide an antibiotic, which is for prophylaxis. Dirty and infected wound, here we do give antibiotic, but this is not prophylactic antibiotic anymore. The reason being the patient has already developed infection, and our strategy at this particular point of time is to apply proper antibiotic to treat the infection, not to prevent the infection. So prophylaxis means prevent, and treatment, so these two have different protocol. This must be properly understood. As you all know, the different suture material that we use during surgery, they are with no doubt foreign bodies. Some are toxic, some are less toxic, some are non-toxic. But even then, as you all know, foreign body acts as a nidus for settling down multiplication and production of infection. So in certain situations, it has been seen that nowadays we have already developed in the different laboratories, different suture materials which are impregnated with antibiotics. So antibiotic coated your surgical site infection. I'll be taking more 15-20 minutes time. I'll just switch over and bring my next presentation in a minute. These are certain repetitions, but I'm going more into details on certain issues. That's why I said that there will be number of repetitions as I go on. I said the surgical site infection risk factors, there are certain patient-related factors. I have talked about age. I have talked about diabetes, other comorbidities which lead to immunosuppression like malignancy, AIDS, patient with chemotherapy, patients with radiotherapy, patients having steroid intake. So these patients are immunosuppressed. So we have to modulate giving these type of medications during a particular surgery to raise the immune status of the patient, thus preventing the possibility of developing surgical site infection. Nicotine in the form of taking cigarette smoking will jeopardize the equilibrium of the patient, and there will be development of surgical site infection. So for any elective surgery, at least one who is a smoker must stop smoking at least 4 to 6 weeks before the time of surgery. Nutritional status, including obesity and weight loss, both will hamper proper wound care and will increase the development of surgical site infection. Drug abuse, prolonged preoperative hospital stay, I have said, preoperative intranasal colonization if the patient has a sore throat or nasal infection before surgery, preoperative blood transfusion should be avoided as far as practical. If it is not essential, preoperative transfusion should not be given. Operation theater related factors include adequate ventilation, must be cool, there will be laminar flow of air, environmental surfaces must be clean, periodic microbiological sampling. So swab should be taken from the floor, from the wall periodically, and culture sensitivity test should be done. So this is the job of, I said, infection control strategy. There is a department in every developed hospital. So we should also start developing all these. There must be proper sterilization of the surgical instruments, and which must be checked at periodic interval. As regards to surgical attire, the OT scrubs must be worn properly. The masks covering the nose and the mouth, cap, shoe cover, gloves, protective eye shield, gown, and drapes must be taken care of properly to prevent surgical site infection. Technical factors include asepsis must be taken in each and every step, and there is no room for compromise as far as asepsis is concerned. Handling and dissection of tissue should be gentle. There should be minimum tissue trauma. Use of surgical retractors should be judicious. Do not pull the parietal wall too much, which will cause skin necrosis, tissue necrosis, and will ultimately be a good factor for development of surgical site infection. Use of energy sources in the form of electrocoagulation. It should be judicious, should not be used too much, it should not be too excess, which will cause burning of the tissue, tissue necrosis, and will cause development of surgical site infection. We should not leave behind a cavity after doing a surgical procedure. So there should not be any dead space. If you leave behind a dead space, there will be collection of fluid, blood, exudate, transudate, and these will form as a nidus for multiplication of organisms and deeper tissue cavities, and will result in residual abscess. We should prevent development of spillage and contamination of the operative field. Proper use of drainage. Drain tubes should be adequate, and if you need to drain something, drainage must be judicious. Suture materials must be as less toxic as possible, and if necessary, we should use antibiotic impregnated suture materials. Wound closure technique must be proper, not too loose, not too tight. There should not be any dead space, I have seen. Proper hemostasis must be done. Post-operative period after doing the surgery, we must take care of the wound. You can have a look at the wound. Our drain has been put here. This is the line of incision. You find the redness, the sutures, stitches have been removed. These have been opened up because there are infection, collection of pus. These are being drained out. So this is an example of surgical site infection. So recommendation during preoperative preparation, is keep the preoperative hospital stay of the patient as short as possible. I again repeat that I am repeating many things again and again to put more emphasis and more importance on these particular issues. These are being repeated again and again. Taper or discontinue steroid as far as practical. Maintain adequate nutrition of the patient. Stop smoking at least 30 days prior to surgery. And when possible, identify and treat all infections which are remote from the surgical site in case of elective surgery, and postpone the elective surgery on the patients if the patient has remote infection. It is proper to have a shower or bath with antiseptic agent or soap night before surgery. Do not remove hair preoperatively unless hair interferes with the operation field. If hair has to be removed, it is to be done immediately prior to surgery, preferably with electric clippers. Wash and clean around the incision to remove visible contamination. The recommendations during preoperative preparation: use chlorhexidine solution or povidone iodine solution, or nowadays there is another solution which is triclosan. So any of these solutions can be used for painting of the operative field. If the patient has sore throat, if the patient has nasal infection, apply antiseptic or antimicrobial spray in the nose if necessary. Control the glycemic status. Diabetic patients have a good control of the blood sugar level and then do go for surgery if it is an elective operation. For the surgeons or the surgical team, keep the nails as short as possible. Remove arm and hair and hand jewelries. Nail polish is not advisable and is discouraged. Perform a preoperative scrubbing for 3 to 5 minutes using chlorhexidine, povidone iodine, or triclosan. Scrub hands and forearm up to 1 hand breadth above the elbow. So this much should be scrubbed during preparation of the surgery. Clean each fingernail before first surgery. After scrub, keep the hands up away from your body with the elbow flexed so that the water runs away from the fingertip down the elbow. Dry hands with sterile towel. Wear gown, gloves, adhering to the principles of asepsis. So in this virtual platform, it's not possible to demonstrate proper wearing of gloves, gowning, gloving, and the scrubbing techniques. So when situation comes, we can have a demonstration of all these activities. Let's hope we'll be away with this situation of COVID-19 and we'll have good time and we'll have good training, good workshop. Regarding the operation theater environment, maintain proper ventilation. And regarding the operation theater at your stage, it's not your time to take care of this. This is the hospital administration and the seniors surgical people to take care of the operation theater. But the important issue for you is to keep the operation theater doors closed except transport essentials. Consider orthopedic implant operations with ultra clear air. Limit frequent OT door opening and number of personnel in the operation. So number of persons remaining in the operation theater for a particular surgery should be as minimum as possible. Cleaning and disinfection: when any area is soiled with body fluids, decontaminate with freshly prepared hypochlorite. No need to perform special cleaning of the OT after contamination or doing a surgery with dirty wounds. Clean the floor with hypochlorite solution after last operation of the day, and disinfect environmental surfaces and equipments after operation in absence of visible swelling. There are certain ways how you can take care of the surgical instruments. They must be autoclaved. The instruments or the utensils which are autoclavable must be autoclaved and must be checked that they are being autoclaved properly. There are new options nowadays. There is plasma sterilizations. This is a gold standard. If it is available, we should make use of this. You don't have to remember much of all these. So there are certain instruments, utensils, which you cannot do autoclaving. You'll have to sterilize them with chemical glutaraldehyde solution, like your laparoscope, endoscopes. These should be kept in a solution of glutaraldehyde, and adequate timing must be maintained for keeping it soaked in that solution, and taking it delivery from the solution must be done following the health regulations. Regarding the surgical mask, I said it must be 3-layered or 3-ply non-woven mask, single use, must cover the nose and the mouth. Cap to cover all the hair. Gloves, preferably double gloves. The inner gloves should be of half size, larger than the outer gloves, and the outer gloves should be of the size of your hand. Cloth gowns autoclave properly and properly taken care of. Eye protection in the form of goggles, unnecessary if you are dealing with some serious infectious cases. Asepsis and surgical techniques. Skin cleaning with alcohol for procedure of less than 3 minutes if no visible sign of soiling is there. So this is important. So rest of the things have already been said, talking about biofilm and talking about antibiotic impregnated suture materials that we have already talking about antimicrobial prophylaxis again. This is for clean and contaminated cases, clean case with implants and prostheses, and for clean cases and with a low minimal inhibitory concentration value of proposed pathogens. High tissue concentration will have to be there, an appropriate half-life, and it must be safe, having minimum side effects. So choosing an appropriate antibiotic for antimicrobial prophylaxis is also important. When do you have to give this prophylaxis antibiotic? Always to be given within 1 hour prior to surgery, but before making a skin incision. That must be remembered. So that is very important. So we are not going into details. Prior to colorectal surgery, mechanically cleansing of the skin bowel, maintain the therapeutic level of the antibiotic to give second dose if the surgery is a long-lasting surgery, long-duration surgery. But as regards to antimicrobial prophylaxis, it should not be more than 3 IV doses. That must be remembered. Use local antibiogram to select appropriate antimicrobial prophylactic antibiotic. By local antibiogram means that local protocol of that particular hospital. It is not present in our situation, but every hospital should have its own protocol, that these are the possible organisms that are causing infection in this particular hospital, in this particular operation theater. So we should use these antimicrobial agents against this organism that must be selected and must have a different protocol for all these issues. Recommendations for post-operative wound care. Protect the incision with a sterile dressing for 4 days. Sanitize hands before and after any change of dressing. So use of hand sanitizer has become an important issue now in this COVID situation. At least we have been trained and we have been made, what should I say? We have been made conversant in using hand sanitizer before and after any work that we do. Use of sterile techniques to change dressings. For changing dressing must be proper sterile techniques used. Patient can take a shower or bath after 48 hours of surgery. That must be remembered. If you dress the wound with an antiseptic cover which is impervious to water, in such patients, without removing the dressing, the patient can have a shower or bath after 48 hours after embarking on the surgery. So specific recommendation for surgical section, cesarean section, we are not going into this. We are not going for any particular surgery or particular subject. So anticipated critical factors will have to be adopted by anesthetic team, by surgical team, and the nursing team. So what are the factors, anticipated critical factors that should be removed are different for different group of team members. So anesthetist will review in one way, surgical team in another way, nursing team in another way. So the details you don't need to know. You have these slides in hand, you can see it later, you'll get them. I think the organizers of this BIMSSCON 2020 will look after these, and these presentation will be made available to each and every participant. So what I'd like to say that surgical site infection is an important factor for having a good outcome following any surgery. So our aims and objectives should be to prevent surgical site infection, not to treat surgical site infection after it has already developed. And if we can follow the instructions, you can follow the principles that has been discussed so long, I'm sure we'll be able to fight against surgical site infection and will be able to win over this problem. With these few words and a long deliberation, I'll make an end to my presentation on surgical site infection control strategies. Thank you. Thank you very much, my dear medical professionals, budding surgeons, budding physicians, and ladies and gentlemen. Thank you. Thank you all.